So, the video is for the benefit of Brendan. Hi, Brendan. Hope you enjoy your very first rotation on nights. I can't imagine a worse way to start residency. So, welcome to South Campus, you guys. Historically, we have not had formalized didactics, and so we're switching to a new model where basically attendings are taking a call a week at a time. And as part of that, we're essentially blocking off our schedule for the week, with the expectation being that we will engage in more formal teaching activities rather than, you'll learn that there will be a lot of teaching on rounds, there'll be a lot of teaching in clinic, there'll be a lot of teaching in the operating room. But I think it's really important to sit down and sort of talk about the literature, talk about why we know or why we think we know what we think we know, and how we use that to influence our approach to patient care. What I can tell you, so what I chose is EC fistulas, or enterocutaneous fistulas. Thankfully, these problems are actually pretty rare because they can be really, really difficult problems to deal with and manage. Why don't we start with, so I know Tommy knows, I think Casey knows, we're going to ask you guys, what's a fistula? Just fistula in general. Fistula in general. Go ahead.
A connection between two things?
A connection between two things. So fistula. Definition, fistula. Connection between two things. In general, correct. Not quite. So orthopedists can use screws to connect bones. Is that a fistula?
Is it a hole in
it? There has to be a hole in it, right? So basically the medical definition comes from the Latin tube. So you recognize that it has to have a lumen, and the formal definition of fistula is an abnormal connection between two organs of the body, or between an organ and the exterior of the body, or an abnormal communication between two epithelialized surfaces. So, what would be a good example of an intentional fistula?
I think you use a fistula in the arm for
Yeah, right. So that's exactly what I had in mind. So vascular surgeons create fistulas all the time, right? So they take a piece of graft tubing and connect in between an artery and a vein in the arm or in the leg. And why do we do that?
It's for hemodialysis.
It's hemodialysis, right? So it has to deal with blood flow issues, right? You need a certain rate of blood flow. Otherwise, it would take 3 days to dialyze. Because we make this connection between an artery and the vein, we can actually limit dialysis to 4 hours. So that would be an example of where we use fistulas normally in medicine, fistulas that are intended to be there. Any other fistulas we use in medicine that we intend for them to be there? What if somebody can't swallow? What do? And we want to feed them. We want to use their gut.
Because, you could do an NG tube.
You can do an NG tube? Yeah, so that would be a sort of a fistula. What about long term? Can we leave the NG tube in for years at a time?
Yeah.
What do we do with those folks? If we want to send them home?
Like a perc tube, is that what it's called?
Yeah, percutaneous gastrostomy feeding tube, right? Yeah, so that is a fistula, right? That is a fistula between the stomach and the outside world. So what kind of abnormal fistulas are there? So enterovesicular. And what is that fistula? What are the players in an enterovesicular fistula?
Skin in the bladder? Or is it the bladder and the gut?
Right, so gut, bladder. So that would be small bowel. So entero, in general, we use to mean small bowel. Small bowel to urinary bladder. Right? So that's a bad one. Yeah, people probably wish that wasn't there. That's pretty uncommon. I don't think I've ever seen one. What's more common than an enterovesicular fistula?
Isn't there also entero?
There's entero, sure. And what kind of fistula is that? We would call that not an entero, but we would call that enteric, right? And that's small bowel to small bowel, right? So those could be a big deal, right? So what if you have proximal jejunum to distal ileum? What is that fistula? How is that patient going to present? So they're bypassing all of that small bowel in between, right? So malabsorption, right? So they're probably going to be iron deficient. They're probably going to, really, really difficult to uptake their nutrition, the proteins, their dietary proteins and carbohydrates. So those patients typically present with pretty significant wasting, loss of energy. What other kind of fistulas? Casey, you can play too. Colovesicular. This is what I was looking for. So colovesicular fistula is far more common than an enterovesicular, and that is colon to urinary bladder. Okay, and what disease process does that usually come from?
Could it come from Crohn's?
Could see it from Crohn's. So Crohn's, you can have these fistulas anywhere. So diverticulitis, much more common to come from diverticulitis. This is fun. Let's do more. What other fistulas can you have?
Can't there be some between like the rectum and the vagina?
There can. What do we call that?
It's like vaginal. I don't know.
Rectovaginal. And what's the most common cause of a rectovaginal fistula?
Can it happen from birth?
Childbirth, right? So childbirth, particularly if they got what at the time of the birth? What do we do to help the baby come out? What is that called? Episiotomy. That's right. So if they got an episiotomy, rectovaginal fistula is a big concern. What other kind of fistulas? There are lots, and all of them are relevant to general surgery. What else?
My favorite.
Enterocutaneous. That's what we're going to talk about today. So what's an enterocutaneous?
The bowels to the skin. Or...
That's right. That's small bowel. Small bowel to skin. Okay. What else? There's colocutaneous. What's that one?
Colon to skin.
Colon to skin. That's right. Okay. Tommy, come on. You got more.
Enteroatmospheric.
So EA. So an EA. So enteroatmospheric. These are a big problem. Did anyone pick up from the reading the mortality rate? What's an enteroatmospheric? It means there's no overlying tissue, right? It means that there's a hole in the small bowel. There's a hole in the small bowel that has epithelialized, and that's a big problem, right? So those the mortality rate associated with an enteroatmospheric fistula is about 40%. So that's a really big problem. What else?
Enterocolonic?
Sure. So entero, we'll call this enterocolonic. Okay, same issues, right? These people are going to be severely wasted, right? And they're probably going to have what else? So let's say it's a small bowel to sigmoid colon. Sigmoid's the tail end of the colon, right? Mm-hmm. So what they've bypassed all of they basically bypassed all of their bowels. So how they're going to present with malabsorption and what else? Where does water uptake take place? In the colon. About how much? About 65%. So you do have about 30-35% of your water intake takes place in the small bowel. About 65% of it takes place in the colon. So if you've got a small bowel to distal colon, they're going to have very little ability to uptake water. And those, meaning they're going to present with, are their bowel movements going to be solid? They're going to be formed? No, they're going to be diarrhea, right? So they're going to be having, anywhere from 5 to 7, sometimes even more bowel movements per day. Lots of severe electrolyte abnormalities. So these are not, they're perhaps not quite as disgusting as an enterocutaneous, but just as devastating from a physiologic standpoint, right? These are things that need to be dealt with. What else?
You can have like one from your aorta.
You can. What do we call that?
Aorta. I don't know. Enteric?
That's right. Okay, so that's aorta to small bowel. How do those present?
Blood.
Blood where?
From rectum. Or I guess you could.
From below.
Yeah.
And what? So they present characteristically with what? Something called a something bleed.
Like
What's the answer, Tommy?
Breaker?
Sentinel bleed, right? And who do you expect those aortoenteric fistulas in?
People who've gotten procedures.
Sure. So if somebody who's had an EVAR, right, or an aortic graft for an aneurysm, they if they have a few days or a week to 2 weeks after they've had that procedure, if they have bright blood per rectum, oftentimes it'll be just that one episode. But you got to take that seriously. That could be a sentinel bleed, and the next thing you know, they're bleeding out. And once it's that breakthrough bleed, the odds of salvaging them are very, very low. So plus that graft has to come out, right? Because it's now communicated with an infected something or other, right? So what else? We're going to keep going.
And then you have all the trachea.
Tracheoesophageal. That's right. These are in the babies. Oops. These are in the babies. Tracheoesophageal. I'm just trying to establish for our brave young new doctors that if fistulas are ubiquitous in surgery and they're a big problem, right? So there's bronchopleural. What's a bronchopleural fistula? Anyone? Bronchopleural.
Pleura in the lung.
And what's the pleural space? It's the space around the lung, right?
Mm-hmm.
So between a bronchus and the pleural space, those are a big deal. Those lead to what? To what? What do we call it when you have air in your pleural space? Pneumothorax, right? So bronchopleural fistulas. We usually diagnose them in people who have who've recently had a lung resection, right? So they've got a chest tube in, and for some reason we can't get that chest tube out. The reason we can't get that, because there's an air leak, right? The reason we can't get that chest tube out is that they've got a bronchopleural fistula, right? What happens if somebody say they get a bronchopleural fistula from tuberculosis? How do those people present? They're going to have a pneumothorax, right? It's going to be a devastating presentation, right? They're going to have a big problem, right? Some of those folks won't make it. So, what other fistulas?
Gallbladder into one.
I was just about to write it. What do we call that?
Choledochoenteric.
Choledochoenteric fistula, right? How do people get those, Tom?
Gallstones.
Gallstones, most commonly.
Oh, that's how you get like a gallstone?
Gallstones, please.
Yeah.
Yes. So we're going to talk about enterocutaneous and colocutaneous, which we've already discussed. Is enteric is small bowel to the skin, and colocutaneous is large bowel and colon to skin. I don't think I've ever seen a rectocutaneous. I've certainly seen anal cutaneous, right? What's another name for that one, Tommy? Anal cutaneous?
Anal cutaneous. Is that like fistula?
Perianal fistula, right?
Oh.
But we've gotten lazy in surgery, so we've shortened that to perianal fistula. But really what that is a anal canal to enteric fistula. So we've already decided that fistulas we define them first by where they come from, right? So how else do we typically classify? This was in the paper or in the textbook chapter. How else do we define? What's most important to us when it comes to defining or describing a fistula?
How new is it?
So acuity, absolutely. Has it been around for a while? So a fistula that's been around for a week, a lot different than a fistula that's been around for 3 months, right? What about behavior?
Output.
Output, right. So output's important. Okay. So there's low output, there's moderate output, and then there's high output, right? What's the low output fistula? Anyone pick it up from the reading?
I think it's like
500 mils a
So
day.
200.
Yeah. The moderate is 200 to 500.
Oh,
High
okay.
is greater than 500.
And this is greater than 500. And historically, what's the relevance of this output?
If it's low, then it's more likely to.
More likely to close spontaneously. And that's fairly dogmatic. I found that to be true. The paper that I sent you, the Vischer's paper, they actually said that was not a finding in their research. That output really didn't have much predictive value. Which ones are more likely to be low output? So something is likely to be high output if it's liquid, right? So where is stool least liquid? In the colon. So colocutaneous, right? The colocutaneous is very likely to close on their own. I don't even usually make those folks NPO. I usually let them eat, and it'll still close, right? We just, we want them to be constipated, so because we don't want liquid flowing through there. So high output, in general, what I was taught when I was sitting in your seats was the more proximal a fistula is, the higher the output's likely to be. So something in the proximal jejunum is likely to be higher output than the distal ileum, right? By the time it gets to the distal ileum, it's lost about 35% of its water. So it's going to be less with liquid. Okay. So what is these can be scary, right? So you come across what you suspect to be somebody who's, maybe they had some sort of bowel surgery about 5 days ago, and you see something come from their wound that smells really bad, and you really don't like it, and you suspect that it might be a fistula. So anyone remember from the reading that I had you to do, what is our first priority? So infection, yeah. We need more specifically. So yes, I would agree. We need to control the infection. But as you move forward in your career, you should always prioritize things very simply based on what is going to kill this patient now, all the way down to what is unlikely to ever kill this patient, right? So infection, people can live with infection for quite some time. But when is, say again?
Resuscitation.
So sepsis, right? So really your priority is sepsis control, okay? And does anyone remember the mnemonic that was used? So what?
Yeah.
So what? Yeah. No, I love this. It's so millennial. So what? Sorry, I'm not allowed to say that, am I? So what's S? Sepsis. Okay, so that's priority number one, right? And what are the things, how do you control sepsis? Antibiotics. So they're going to need antibiotics. So this is multi-pronged, right? Tommy, what's the number one principle in sepsis control? Source control. Good. Let's do this the right way. Source control. Okay? And then antibiotics. Right? So antibiotics, not really source control. You're just trying to fight off the bacteria that's already gotten there. How else do you control it? So how do you get source control?
If there's an abscess, you have to drain it.
So drain the abscess. Okay. And that can require IR, right? It could require going back to the operating room. You hate going back to the operating room on these people. It can be really, really hazardous. But certainly it is within the realm of possibility that you might have to take this person back to the operating room to get full control of their sepsis, right? So by antibiotics, IR could also mean surgery. Okay, antibiotics. Do we just pick one? Ansef. Let's throw them on some Ansef.
It would depend on where the infection.
Do you know that right away?
No.
You don't.
Broad spectrum.
So broad spectrum, right? So broad spectrum antibiotics. So you always start when you're treating empirically, right? Meaning, what does it mean to treat empirically? Right. It means you have no idea what you're treating, right? You know that there's an infection there, but you don't know what's causing that infection. So we say broad spectrum. What are the two most common ones that we use in broad spectrum? Vancomycin, right? So Vanc gives you the MRSA coverage. Zosyn is everything else, right? There are other options, ciproflagell, so some sort of fluoroquinolone flagell. If you're in the military, which I am, one of our favorites, ertapenem. If you're not in the military, but you hate vancomycin like I do, meropenem's a good one. Right, so carbapenems have pretty broad spectrum sort of enteric coverage, right? Ciproflagell, did I say that? Yeah, I did. I said that. Okay. So between draining the abscess and putting it on IV antibiotics, you should be able to get fairly robust control of their source, right? Sometimes it requires multiple CT scans. Sometimes they'll get better with drainage of one, and you got to send them back. Or they start getting sick again, so you send them back for another CT scan. You realize there's more fluid there that needs to be dealt with, so you send them back for another procedure. So this is sort of a moving target. It sort of requires ongoing efforts, right? This is rarely in anywhere in medicine is treating somebody completely just a one-up sort of deal. We do have, in surgery we have a lot of those, right? So if somebody comes in with cholecystitis, we take out their gallbladder and they get better. Lots of times it's a process, right? It's a treatment plan. It's not just one thing and then have a nice life. Oftentimes it's an ongoing relationship, which is one of the nice things about surgery. So what is O? Optimization. What does that mean?
You want them to have very like albumin.
Okay. What's the best laboratory value for determining somebody's nutrition status?
Well, this likes albumin.
That's not what I asked. I didn't ask what this one likes. I said, what's the best?
Prealbumin.
Prealbumin, right? Well, we don't get prealbumin very often, do we? Right? So prealbumin is the best. But what we have learned is that albumin actually correlates really, really well with things like mortality and surgical outcome, right? So what was the number that this paper gave? There's
2 something.
so they said the Vicious paper said 2.5, right? 2.5 milligrams, 2.5 milligrams per deciliter. I gotta tell you, Tommy, you comfortable with that albumin? Would you do an elective case on somebody with a 2.5?
I would aim for 3.
Yeah, no, it's pretty standard, even 3.5. So, three. I would say that 3 is absolutely a basement. That going below 3, you're asking for trouble. Unfortunately, people with fistulas, particularly these high output fistulas, it is really, really difficult to get that out. The amount of nutritional wasting that they suffer at the hands of that fistula can be pretty profound. So, but I would still say that you should make every effort possible to get them above 3 before you try and go back and close that fistula. Otherwise, you're asking for another what? Another fistula, right? You're going to give them an anastomosis. They can't heal that anastomosis. and suddenly you've taken their old fistula that was controlled and you've given them a new fistula that's not controlled. So 2.5 is well below my comfort level. In my elective practice, so these big nasty hernias I do, if their albumin is below 3.5, I say have a nice day. That's I refer them to a nutritionist. We get that albumin up above 3.5. What is your albumin? What do you guys walk around at? 4 to 4.5. Absolutely, yeah. So do you think of a drop of 1.5? That's a pretty substantial drop, right? That's almost a 50% drop in albumin. That's not somebody who's going to do well. Albumin takes how long? How long does it, in general, over what time period is it reflecting nutritional status?
30 days.
It's about 30 days. It's at least a month, right? So pre-albumin really is from day to day, right? So pre-albumin might be 25 today, it might be 17 tomorrow, it might be 7 the next day. Albumin does not respond that quickly, right? Albumin is synthesized where? In the liver. That's right. So, and it's not easy to fix, or it's not easy to make. So that's why it's a better estimator of nutritional status over the course of a month at least, if not more. What is W? Wound care. So the wound care sort of has 2 hits, right? First hit is this first one, right? Their nutrition sucks. We're going to have trouble healing people whose nutrition sucks. What's the second? What's the second issue? So their wound is being bathed in what? It's poop.
Yeah.
Is poop clean or dirty?
It's dirty.
It's dirty. So wound care is challenged both by their nutritional status as well as the environment in which that wound is being expected to heal. So what do you think then should be our priorities in terms of accomplishing meaningful wound healing? What do we have to do? Improve nutrition. Just dealt with that one. We have to figure out a way of controlling contamination of the wound. That can be quite challenging. I do have some pictures of when we switch over to. Actually, it might be. I want to show some pictures that I forgot. Can we flip that guy back on? Oh boy, where'd it go? Sorry, guys. It shut me down. Why did it do that? Why does the system torture me?
Oh, it won't let you log in with your NetID, I think. It might. Okay, it will.
That's not right there.
It wouldn't let me.
I mean, that's all right. So I'm gonna pull this down real quick. Can we kill the lights real quick? Yeah. All right. So the patient just had an operation. In this case, it looks like the patient had a G-tube placement. And difficult closure, you can tell because this is called a retention suture. This helps hold the abdominal wall together, right? What do you see in the wound there? Anything that would make you concerned? Probably. Well, this could be fibrinous exudate. It could just be necrotic fat. I don't know.
It's dark.
I don't really see. So I see something bilious. Yeah, it's either bile or poop. Probably a little bit of both. So this is. You can tell where, in part, you can make educated guesses about the origin of a fistula based on what it puts out. So this is probably a pretty proximal enterocutaneous fistula, right? And also they would probably apply that duodenal bulb, placing that G tube. Might even be leaking from the stomach. You can get bile leaking from the stomach. So here's these two. These are enterocutaneous fistulas. There's no output, right? At least not that we can see based on this picture. These are not my patients. These are just stock photos I stole from the internet. You want to know who this guy is? So that's Alexis St. Martin. You want to know who Alexis St. Martin was? So Alexis St. Martin was a fur trapper, Canadian fur trapper. Shoot, my technology is revolting. So Alexis St. Martin was a Canadian fur trapper who, in 1822, was shot in the stomach and the chest by a musket, and he came across a doctor, a surgeon in the area of Michigan, by the name of William Beaumont. He was an army surgeon, and Dr. Beaumont was super interested in this because this was really the first case of anyone that had ever been described who had suffered he developed a gastrocutaneous fistula. And he survived it. Somehow he recovered from this musket shot and he survived it. And so Dr. Beaumont spent the next 58 years torturing Alexis St. Martin. Basically, paid the guy's living if the guy would let him run experiments through his gastrocutaneous fistula. So he did all sorts of experiments on nutrition and digestion. But we know much of what we know about fistulas based on Dr. Beaumont's recordings of his work with Alexis St. Martin. So this is, what kind of fistula is this? Looks like there's our fistula, right? Everyone appreciates that? Looks like it's coming from this structure there. What's that structure over there? So Casey, how do you read a CT scan?
Well, you orient yourself.
Okay. So how are we oriented?
Feet coming towards you, lying on the back.
Yep.
So it's going to be the left side.
Uh-huh. And what structure sits along the left side? The colon.
Well, is that the colon?
Specifically, what part of the colon?
Flexure.
So the splenic flexure is up here.
Okay, so we're below there.
We're down by the pelvis, right? So what sits down here by the pelvis?
The sigmoid.
Sigmoid. Yeah, so this is probably descending colon. Looks by the time it's sigmoid, it's already starting to dive into the pelvis, right? So it starts going close to the midline. So that's probably the descending or the left colon, right? What's the most likely cause? I'm not sure that's the case in this patient, but what's the most diverticulitis? So this is a colocutaneous fistula that's probably developed from diverticulitis. Cancer can do it too. I don't see anything that looks like cancer there. So we talked about sepsis control. You've got a fistula, looks like it's draining, right? This is our problem over here, right? Is this patient going to get better as long as that's there? No, this patient's probably going to get worse, right? So this is what we're talking about when we talk about sepsis control. So anytime you come across a patient like the very first slide we saw, the very first thing that you should do is do what? You got to scan them, right? And ideally, you want to give them some contrast. The reading said we give them contrast both by mouth and by rectum. I oftentimes give contrast by fistula, but much later during the operative planning stage. But you want to know where that fistula is coming from, and you want to identify output that's outside of the bowel lumen. And then that person either needs some sort of operative intervention to drain that fluid, or more likely, that looks like something that IR is going to be able to get. So let's turn that camera off real quick. Okay, so what's A?
Anatomy.
A is what?
Anatomy.
Anatomy, right. So how do I just mentioned this.
Scans.
So scans, what else? Fistulograms, what's a fistulogram, Tommy?
So you should contrast do the fistulas, and then you can get X-rays and see how the fistulas connect to one another.
Right.
Which ones go proximal, which ones go distal.
Right, where it is in relation to the ileocecal valve, where it is in relation to the colon. T, timing of surgery. So when I was growing up, many people would say I have not yet grown up. So I guess what I'll say is when I was a younger surgeon, we were taught do not, under any circumstances, go back before 3 months. You really don't want to wait longer than 6 months because, the longer you wait, the more scarred things get, the more frozen the abdomen can get. The point being in the paper said that what was the time cutoff that the paper gave us? They said after 7 weeks they had no spontaneous closure of the fistulas. Does anyone remember their median day of operation? 53 days. Yeah. So that's under 2 months, right? So about when I was brand new out of training, I had a fistula that developed after a particularly difficult case, and he was a cancer patient, and I needed to get him to chemotherapy. And at about 7 weeks, his output was still about 1,500 cc's a day. I made the decision that I needed to get him to chemo, so I took him back. It went okay. But he was. At that point, he'd been on TPN for a full 7 weeks, and his nutrition actually was really good. He was right about 3.8, almost 4. Sepsis had been controlled for weeks. I'd been doing these crazy things with the wound vac to try and redirect his fistula so we could decrease his output. That had worked a little bit, but he was still having pretty high output. So we took him back at about just over 7 weeks, and he did well. He made it to chemotherapy, and actually his cancer was cured, thank God. But just having had a fistula portends a poor prognosis in terms of cancer treatment, just because of the nutritional deficits. That it's a bad problem. S is surgical strategy, right? What's the surgical strategy most commonly?
Well, you limit the anastomoses.
You want to dissect out the enterocutaneous fistula. You want to make as few anastomoses as possible, and you want to make sure that you cover up your anastomoses so that you don't make new easy fistulas.
Right, and full mobilization of the entire length of bowel. Because if it's not fully mobilized, meaning tethered, right? So you leave a little loop of distal bowel tethered. What have you potentially just given the patient? You guys know?
It could be a source for
or a volvulus or an obstruction, right? This is potentially an area where the bowel can get kinked. So it's always important when we talk about fistula. So the question becomes, we would rather not do surgery at all on these things, right? We would rather have all of these things close on their own. Unfortunately, we now know that that's probably wishful thinking about how many of these, according to the paper, close on their own. About a third. So the majority of these folks at some point are going to need some sort of operative intervention. But we could talk about the things that, if you were able to predict which ones are going to close on their own, you can make intelligent decisions about who to keep NPO, who you can go ahead and feed enterically, because which is better, TPN or regular feeding by gut? Regular feeding by gut. You'd rather use the gut. So if you have no real hope that the fistula is going to close on its own, you might as well just go ahead and feed them, right? If you know at some point, particularly if you've got control of that output. Yeah. So, what are the friends of a fistula? What keeps a fistula open?
Foreign body.
Foreign body. Right? So, a percutaneous gastrostomy tube, that's a foreign body, right? We are using a foreign body to artificially keep that fistula open. Okay?
Infection is fun.
What is R? Radiation. Who said radiation? Oh, okay. I thought it was one of the third years. I was going to be impressed. I was going to say, you graduate, move on to medicine. Okay? So somebody who's had radiation for cancer, right? That tissue is probably scarred, probably not capable of healing and sailing on its own anymore. What's I?
Infection.
Infection or inflammation. Not all inflammation is related to infection. Okay. What's E?
Is it like epithelial?
That's right. So why do earring holes stay open?
Epithelial.
Because they get epithelialized, right? They form their own skin. Okay. What's N?
It's
Neoplasm. That's right. So if there's a tumor there, do tumors heal normally? No. They've lost their ability to right. That is one of the hallmarks of the progress of cancer. Something that looks like the tissue it came from. A more aggressive cancer is one that looks nothing like the tissue that it came from. So, and then what's D?
I think it's distance.
Mm-mm.
Or is-
It's dis.
Distension.
Why do we scope people after diverticulitis? What are we looking for?
Oh, cancer?
Distal obstruction.
Distal obstruction.
Oh, that's right.
That's
Yeah.
right.
Which is
Distal
cancer.
obstruction.
That's true.
Wait, isn't it also output too? Because like the higher the output, then like the fistula is not going to close, and then also length as well. Because like the shorter the fistula,
That's not part of the
Then it
mnemonic,
wouldn't
man. I need the
be-
mnemonic to
Yeah.
work. What are you trying to? You're trying to hose my mnemonic here.
okay, never mind.
That's not going to work. So those are the traditional friends of a fistula. Okay. So let's talk about the phases of the enterocutaneous fistulas. There are three phases, right? What are the three phases? That's phase number 2. What's phase number 1? So there's development, right? Development occurs in what period of time?
It's like 10 days.
First 7 to 10 days, right? Can you operate in those first 7 to 10 days?
Yes.
You can. You can. Do you have to?
No.
No. Sometimes, in fact, in some cases, it's contraindicated. What was the specific contraindication that the reading mentioned?
It was extensive adhesive.
So extensive adhesive and why not operate in that case?
Agglutinated bowel.
Agglutinated bowel. What's agglutinated?
I do not know.
I don't know.
It becomes sticky, right?
Okay.
It becomes clumped. So what happens when your red blood cells agglutinate?
They stick together.
They get clumped, right? Platelets agglutinate. They get clumped, right? So bowel tends to clump. If you operate in that setting, you're very, very likely to injure more bowel. You had 1 fistula, now you've got 4. That's a problem. So in what circumstances would you absolutely positively operate, Tommy?
If the patient was hemodynamically unstable.
So that's number 1. It's number 2.
If,
So why are they hemodynamically unstable? Because they're bleeding?
well, one, yeah. I mean, if there's perforation, if there's bleeding that's uncontrolled.
Right, so a fistula, by definition, there's perforation, right?
or
First
uncontrolled perforation that's causing like sepsis.
sepsis, septic shock. So they're hemodynamically unstable. If they're hemodynamically unstable, they're in septic shock. Got to operate, right? You're not sitting and watching that. So the septic hypotensive does not get less hypotensive. It gets more hypotensive.
How does that work with the whole like don't operate until they're not septic anymore thing?
But we're not talking about sepsis. We're talking about shock,
Oh,
right? So they're in septic shock, right? So septic is one thing.
Okay.
Septic shock is something entirely different because the outcome of not intervening in septic shock is death. There are other interventions for sepsis other than surgery, right? So drainage, IR drainage, antibiotics, those sorts of things. But septic shock, there is but one outcome for that if you don't intervene, and that's death. Okay? What are the other circumstances in which you absolutely positively operate?
I mean, if it was like a enteric fistula,
Sure.
then
Yeah.
you would have to operate.
So that's hemorrhagic shock. Yeah.
I'm drawing a blank.
We're talking about ECFs now.
If they're so dehydrated, like I'm not
So
sure.
why would they be? You're getting there. Why would they be so dehydrated?
If the output is extremely high, that
Right. So what do you have? You have
like a sort of proximal fistula that you're unable to resuscitate the patient.
So you have an uncontrolled fistula, right?
Yeah.
So all these other clever maneuvers, you've tried everything you can. He's still dumping out. You can't manage the output. They're getting, they're having persistent electrolyte abnormalities. That's an uncontrolled fistula. You got to operate. You got to find a way to a surgical way of getting control of that fistula. You've tried everything else, right? They may not be shocky at all. They may be doing great. They may feel great, except they've got stool coming from everywhere, right? That's an uncontrolled fistula. That has to. I mean, if you've tried everything you can, and you're still unable to keep up with their electrolyte needs because of the output of that fistula, you're going to have to operate. Any other situations that you can think of? There really are the main two. I can't really think of any. If you think of any, feel free to chime in. So what are your 4 clinical priorities in that first phase, that development phase? Tom has already said 1. Resuscitation, right? So resuscitation is critical. What are the 2 things that they're going to need? They're going to need fluids, and they're going to need, yes, at some point, probably not immediately. We don't start feeding these folks immediately. They're going to need electrolytes, though, right? So that's something that you can get from your nutrition, but you can also give it to them IV. So you're going to have to correct their electrolyte imbalances. And what's the most important one? That affects cardiac contractility. Say again? Potassium. Right, so potassium. Potassium is going to be really, really difficult to control. Where do you mostly get rid of your potassium? Your poop. That's right. You mostly poop out your potassium. So it's going to be very, very difficult to in particularly someone with high output, it's going to be very, very difficult to get control of the potassium. We already talked about antibiotics. We talked about undrained collections. So once you've got them resuscitated, their blood pressure's up. They're making pee, and we titrate pee to what number? How do you know when somebody is resuscitated from a fluid perspective? How much pee do you want them making? Well, 30 cc's per hour. That's historical. The number that we use. We now usually go on. Right. So 0.5 what? cc's per kilogram per hour. So you should get away from this because we're all different, right? Like my urine output is going to be a lot different than urine output. Say we both need to make 30 cc's an hour, probably not true, right? It's to say 0.5 cc's per kilogram per hour. That's a little more accurate, a little more reflective. It makes you sound, and frankly, it's going to help you take care of patients better because you've got a more reliable.
Take your weight in kilograms divided by 2. That's how much you're making every hour.
Okay, so we've got the development phase. What's the next one? Early. And what's the time range on that? 1 to 6 weeks. Okay, can we operate, Tommy? Why not?
Because you need to wait until all of the information goes away before you can operate.
So you've got very, very friable tissue, very, very friable bowel. I mean, you look at that bowel funny, it might break apart on you. I mean, it really is that dramatic. So that 1 to 6 weeks, I guess if you have to, if there's some sort of disaster and you have to, but it's probably not going to turn out well. That's a really, really tough time now. And then we've got, so what's going to be your priority during that 1 to 6 weeks? It's going to be the same, right? So nutrition is going to take on a much more important role, right? Sepsis, right? So these are folks that may recurrently develop sepsis. And what do you do if you're 5 weeks in, you think you've got good control of this fistula, but suddenly their white count's going up, they're febrile, they're tachycardic. What's your first step? You're going to scan them, right? What do you think's happened? Somehow that effluent has found a different path, and now it's draining into their abdomen and not through the fistulist opening as it was before. So these really are recurrent issues. I mean, they're turning septic again. We got to scan them. We got to look for where that fluid's going now. Make sure that there's not something undrained. And then the other is going to be wound care is going to take on much greater importance here, right? Because they've still got a wound that's trying to heal. What if there's someone on steroids, right? Anything that you can do to help deal with the consequences of steroids on wound healing in these folks? Vitamin A. So vitamin A helps counteract the wound healing blunting effects of steroids. So then after 6 weeks, you've got the late. Okay, what's your goal in that late? Why are you waiting so long? Tommy already said it. This is just to cement it in. What do you want to go away? An inflammation. You want those adhesions that are going to form. You want it to be nice and firm, nice and mature, and then we already talked about the surgical priorities. Closure. We talked about only about a third of these are going to close spontaneously. They're more likely to close spontaneously if we're running out of time. Sorry, they're low output, or what's the other issue from the textbook reading?
You have an abdominal wall defect.
Right. So if their abdomen is closed, they're far more likely to close spontaneously. If they've got an open abdomen, you will encounter patients with open abdomens. That's probably a fistula that's not going to close. So, and that has to do with the amount of tissue that's overlying, the amount of tissue that can collapse. Some of my colleagues will use wound bags to try and get that tissue to collapse and propagate or encourage spontaneous closure of that fistula. I suspect it works occasionally, but it's probably not the best strategy. Many of these people are going to need operations. Albumin, just a reminder, albumin levels are really important. First question you should be asking of anybody who's having trouble with wound healing or fistula closure is what's their albumin, what is their nutritional status. You can do things like 24-hour nitrogen levels or nitrogen balance. That's a little more, that's not something I use a lot. It takes a lot of calculation. If I'm getting that far, what I'll do is I will consult a nutritionist to do that for me. And then the last, so about this time when person is optimal in terms of their nutrition status, and I'm starting to think, okay, this isn't going to close. I'm going to have to intervene here. This is the point where I'll get a fistulagram because I want to know where along the bowel is that fistula. So, any questions for me? I know this was kind of a deep topic for you guys to start your first day of your surgery rotation. You already had the shock, so. This is definitely one of those situations where shock is probably, so these people are going to be in shock at some point. There's no question.
So you said that albumin is important for wound healing, but also what about people's patients with diabetes?
So what is glucose control important for? I'm a stickler for this because I operate on a lot of diabetics. Because diabetics tend to get these ugly hernias. I'm a stickler for this.
It can cause stiffening of vessels.
So it can definitely, so over the long term, they can have wound healing issues. But what's more important with diabetics?
The nutrition.
It's going to be the infection, right? So diabetes is a much more relevant risk factor in terms of infection, right? These people, if their blood glucoses are running 220 all the time, they're going to have recurrent infections. So the best thing you can do for your diabetic patients is keep good control of their blood glucose. When I was training, the number one thing we got yelled at for was failure to maintain tight glucose control. There's been some data that's come out since I was a resident that has shown the negative side of hypoglycemia, right? So we were having patients with a lot of hypoglycemic episodes. And what's the importance of that, Tommy? So your trauma patient comes in after a car accident, they're diabetic. You throw them on an insulin drip, and they've got several glucoses down in the 60s.
Hypoglycemia is worse than hyperglycemia because you start messing with the brain. And the brain needs brain needs glucose.
That's right. So it can dramatically worsen traumatic brain injury. What's the other issue? I forgot. It's been so long. It'll come to me. There's another issue. I forgot. Hypoventilation.
When they start crashing, would it be hard to resuscitate them because they're like.
If they're retaining CO2, lots of good reasons not to let them retain CO2, but often in TBI patients, we'll allow them. We'll do permissive hypercapnia, right? So you sort of get down into the weeds here. But the best thing you can do for your diabetic patient is not allow them to get their glucose above 180 or so. Any other questions?
The sweet range is 140.
That's what they started teaching us at the end as well. Okay, Brandon, have a good night. Call if you need help, okay? And don't panic. It'll be okay.